Hello, everyone. Once again, welcome to the session. We have so far four speakers on, and I will start by introducing them. We have Dr. Catriona White on the call. Dr. Catriona is a clinical pharmacologist, a physician, and a principal investigator. She has a BS, an MBCHB, and a PhD from the University of Liverpool, and currently works as a Wellcome Clinical Research Development Fellow based at IDI. Her specialty is in understanding safe and effective use of medicines in populations that are usually excluded from clinical trials, including pregnant women and breastfeeding mothers plus their infants. Her skills range from clinical trials, clinical management of complex and acutely unwell patients, and she also has expertise in pharmacokinetic modeling and public engagement. She has won the British Pharmacological Society Prize for Equity, Diversity, and Inclusion in year 2021. And she's usually, she frequently speaks at career events and mentors junior science. Thank you, and you're welcome, Dr. Catriona. On the forum also today, we have Dr. Miriam Lekker. She's a medical doctor, a research scientist, and she has over 10 years experience in academia and working with organizations. Her research interests in HIV-associated cancers, including Kaposi sarcoma and cervical cancer. She's also a faculty in the clinical epidemiology course of the University of California, San Francisco, and implementation sciences course at Makerere University. She is also a board member of various organizations, including also Reach Out Mbuya. And she's been a co-founder of AWISH, which is a hub for women in science and in research. Next, we have Dr. Brian Ahimsiwe. He's a medical doctor by profession. He holds a bachelor's degree in medicine. He's been a global shaper under the World Economic Forum, which is a hub, and Young Emerging Leaders Project Fellow with Leo Africa Institute. He's been a co-founder of and a clinical lead at MScan Uganda, and he's also a CEO at Kangaroo Plus that makes neonatal jackets. At MScan, Dr. Imsuga is responsible and in charge of clinical protocol, documentation strategy, and he also holds experience in business, research, and community health. Well, we also have Dr. Barbara, who is a specialist in infectious diseases and has worked at infectious diseases for a long period of time, since 2004. She's currently the head of research department at the Institute, and she has designed and implemented several observational cohorts at the IDI. And she has participated in a wide number of clinical trials. She has also mentored and supervised several masters and PhD scholars at the Institute. Currently, she's the PI of a COVID-19 cell survey among people living with HIV, and the study is addressing COVID-19 vaccine hesitancy. We also expect Brian to join us. He's also a co-founder of a project called Uganda. He has 15 years implementing, he has spent 15 years implementing projects to do with innovation. And also these projects also aim at scaling digitally inclusive health systems, which are to be built on for IR technologies and business models. So you are all welcome. Today's discussion is based on, we are looking at health innovations in addressing equity and inclusion in the area of health. So I would request my speakers to say hello to the participants as we move on. I'll start with Dr. Catriona White, please.
Good morning, and thank you for the opportunity to take part in this very exciting panel discussion. I think the issues we discussed this morning are key, and we very much look forward to your interaction and participation. Thank you very much.
Welcome, Dr. Catriona. Dr. Miriam Lekker.
Thank you, and hello everyone. It's a really great pleasure to be here to discuss something that is changing more rapidly than any of us could imagine. It's going to be a pleasure to share my experiences, to listen to my fellow panelists, and also to learn and hear from everyone who has chosen to be part of this breakout session. Thank you.
You're welcome, Miriam. Let me also call upon Dr. Himsiwe Prosper to say hello to the participants.
Hello, everyone. I hope it's a good morning. Where are you from? Yes, it's a pleasure to join in the innovation conference 2021. I'm very glad to share my insights on innovation, and also learn. Eager to listen on from this and their questions. Thank you.
Thank you, Dr. Prosper. Lastly, let me call upon Dr. Barbara to say hello to the participants.
Sorry, 1 second. Hello, sorry, 1 second. I lost my earpiece. Good morning, everyone. I'm trying to put the video just for a few seconds. Good morning, and you're welcome to the session. Thank you.
You are welcome, Dr. Barbara. So to kick off, as I said, we are looking at innovations in terms of addressing health inclusion and equity. We've all heard for a long time that in the health sector, we need to look at these two words that are really important: equity and inclusion, which means that equity, we are looking at ensuring that both healthcare workers and patients that we serve both have what they need to achieve the best out of the services that they are looking for. The doctors have what they need to deliver the information or the treatment to the patients, and also patients have what they need to get in and out of the facilities and get out with what they have gone to get. While inclusion, we also look at both employees and patients voice having to get high quality of care, and also we encourage the presence of diversity as we look at this inclusion. So in today's meeting, from the speakers, I want to know to what extent have we used the technology or the evolving innovations to keep our work going, given the situation that we are in, the situation of COVID pandemic that has led us into continue our services in the business unusual, in the aim that we see that our patients or our clients that we serve continue to engage. So we could give a few experience and probably talk about this in wide. So I will start with Dr. Miriam to let us know, tell us more about how technology has helped us to keep the patients engaged.
Thank you very much, Hope. I'll just interestingly talk about how we went back to the very basic technology, which is the use of the phone, the cell phone, because a lot of our patients, especially in our research studies, could not come to hospital either because transportation had become too expensive or it was a lockdown period, and many of them were on follow-up. So we simply moved back to basic technology, a phone call. So a lot of our work moved from in-person visits when patients were not very sick to talking on the phone And when they needed referrals, we talked them through the referral process using a phone. And when they got to the facility where they were going, we talked to the clinicians who were seeing them on their cell phones as well. So we really went backwards to that basic technology. And then also we took advantage of like what we're doing right now, conference calling, because we have sites in multiple places throughout the country, but also in other countries in Africa. And in the past, if you were doing something like protocol training, you're just checking up with the sites, you had to go there in person. But during these last 2 years, we have learned and adapted very fast the use of electronic calling using like conference calling facilities. And interestingly, we've been able to train sites to actually start new sites completely. And it's going much better than we had actually hoped. So it was really a use of already existing technology, but making it more, using it more to the capacity that it has, and even probably more. So that has been part of my experience. Thank you.
Okay, thank you, Miriam, for your experience. Getting to Dr. Barbara, I know she's having we saw that she has she's a PI on various studies in IDI. Did you get any issues to do with patient follow-up? How did you employ any tool that you employed during the COVID lockdown that helped your studies and your clients moving during the same time that we had lockdown?
Thank you very much, Hope. So, of course, I wouldn't want to repeat what Miriam said. So even for us, it's been mainly really the phone, because, you know, like, not everybody has a smartphone, so you really have to go back to basic calls, but that still helped us. For one of the study, I remember that we asked patients if they minded if we were doing visit by phone, and I remember that the answer was very positive. They were really in the lockdown, and they were saying at least someone is checking on us. So this is very good. Maybe to add something that has not been said, in my department, particularly the research office, we actually been coming up ourselves with some innovations. For example, we actually moved from physical study binders to electronic study binders because, of course, of access. People could not access their files. And also with limited with people not able to move all the time, there was also a problem with the monitors. So at least these days, monitoring visits can be not totally, but greatly done using an electronic binder, and the monitor doesn't have to be physically on site. Maybe just the other innovation I want to mention is that last year we activated the IDI Research Ethics Committee. Was accredited, and we started it, and it's totally virtual. We had already 6 or 7 meetings. We don't sit around together. Presenters don't come around, and we actually even get people presenting from abroad. People who will conduct research in Uganda, but are presenting, for example, from Kenya, from the UK. So that virtual format has become very convenient. Thank you.
Thank you, Dr. Barbara, for submission. And I think she has really hinted on something that is important, that so far we are conducting our meetings, the research meetings, and including people not from here, and we are able to engage with them via the use of technology. And how research also has evolved to have a submission of our protocols and other things done via the net. Thank you so much. Dr. Catriona, there has been a remarkable disparity in ensuring access to equitable healthcare, especially in the era where we are adopting these new technologies. And so what do you think should be done to inform the advancement of these technologies as to address the key areas of bias and inequality that are already existing, and people have bias already? So what should we do as we introduce the technology and all these new ideas for people to uptake? And what should we consider to reduce the bias and the issue of inequality, the populations that we serve?
So that is an absolutely fantastic question. And I think all over the world, we have experience of how technologies have helped us in our clinical care, in our research, in our networking, and possibly even other aspects of our lives. However, what seems to happen is there's always a marginalized group. And sometimes by bringing in technologies, you just change who that excluded group is. So for example, Dr. Barbara and I yesterday had a conversation about high income countries, Italy and the UK, where many technologies have been adapted in COVID, but there have been real challenges faced by the elderly in accessing these. So suddenly the elderly who previously have had really good experience of healthcare are the ones that are marginalized perhaps in favor of the youth. In Uganda, it's going to be different. It's going to be a bias towards those who are technology literate, who have access to a device perhaps, who have access to a power supply and so forth. I think in any part of the world, if you're introducing something new, the first place to start is with the communities. So I think we need to go out into a particular community and actually ask. So do some mapping. Some of this work has already been done. So we know, for example, we talked about basic phones. Dr. Miriam talked about basic Nokia phones. Many people have those. So who has those? What about smartphones? Who has those? How do people want to receive healthcare messaging? Are people able to engage with it? So I think in order to reduce inequity, we have to actually go out into the community and have community engagement right from the very start. And not just community engagement, but I would also think community empowerment and collaboration, bring in community members as key stakeholders alongside innovation projects. So that's one of my thoughts. In terms of how we actually do that, I'm aware the area is vast, and perhaps that's something that we can continue to pick up upon. Thank you.
Thank you, Katrina, for your good submission. And I think that has addressed and hinted on how we can address bias and inequality. So Dr. Prosper, I know you've been involved in innovation of various services, putting them up to help out to the patients that we serve. Can you let us know what you've been doing and probably what you've invented, how it has helped the population or the clients that we have in this area? Thank you.
Thank you. Again, I'm glad to join in. I will agree with the rest of the panelists that COVID came and created, new needs of healthcare. I work with a startup called MScan Uganda that delivers portable ultrasound devices that can be used to scan pregnant mothers in resource-limited settings. That includes villages, refugee camps, fat-rich areas like islands. So we're already doing some work around that. We had a scan in Kalangala Island, Kalangala district, serving a population of about 80,000 people. And we were actually carrying out scans. So mothers who previously were taking 2 hours to reach the mainland to get an ultrasound were able to actually now receive an ultrasound 3-4 months before their delivery date at the island, and complications that were detected, the mother would be, referred for care by by a qualified health worker. They would be worked on as soon as possible. But I think for me, COVID kind of laid bare the inequities we had, and inequalities we had to access of healthcare. There are long-standing unmet needs that have existed, especially for resource-limited settings that had to be addressed. So when COVID came, those were exacerbated with the lockdown and everything. So for us, we moved on actually with the restrictions, some of the restrictions that were holding us back, like moving to communities, setting up new IPC, protocols before we could actually visit some of these centers. We had to actually invent the way we actually deliver some of the medical outreaches that we do. At MScan, we're able to develop a new home-based ultrasound service because people are scared of going to hospitals. Hospitals were full with COVID patients. So we reached out to mothers in their own home. So they would book with us, and we actually get a healthcare personnel, a radiographer, who would move with the PPE, the protective personal protective equipment, and be able to do the scan in the comfort of someone's home. So as a company and a startup, we had to invent ourselves, both here in urban centers where we recognize the need for care, especially in people's homes, and also the existing healthcare needs that were in communities that are marginalized, like distant islands, refugee camps. Actually, our latest outreach is with Bidibidi refugee camp, where we had a medical outreach there, and we actually noted that mothers, it's the same condition. Mothers cannot either afford the existing ultrasound machines are too bulky that they cannot be maneuvered in a refugee camp, access to electricity, healthcare personnel. So those are things that I think as healthcare innovators, we have to navigate to be able to deliver ultrasound or healthcare in general. So I'll definitely agree with Dr. Catriona that we as healthcare innovators, the responsibility is on us to develop solutions alongside these communities and engage with them right from the inception. Thank you.
Thank you, Prosper. This brings me to the next proper issue that probably have you thought of engaging with other stakeholders, because we know that with the technologies developing, there is already inequalities in communities accessing healthcare services and the other services that we provide. So is there any...
You had a problem, Ivan.
I'm sorry about that. Is there any benefit in engaging the other stakeholders to remove or curb the inequalities that exist? Dr. Barbara, you can help us probably throw more light on that. If collaboration could, with other stakeholders, could help us to kind of curb the issue of inequalities as we serve our people.
So yes, I think of course that can help. I think I'd like also to bring back what Catriona said, that what we need to engage first, I think even before other stakeholders, there is the community, because sometimes technology needs either to be adapted or to be understood by the local context before actually you try to use it. I think that we have learned a lot during these couple of years, and I think that it should really be us, the community, and then I think that we should probably involve, let's say, someone like IDI. I think there should be more discussion probably with the Ministry of Health, if some of these innovation can be actually used really to scale up and continue national programs. And then again, probably I would say that innovation that require use of phones, use of internet. I think we should also actually approach the phone companies and work all of us together, because right now, for example, all these innovations that are internet-based are quite expensive. Internet is very expensive in Uganda. And so we are all happy that we can Zoom, we can all do our things remotely, and we can have a virtual conference, we can have a virtual research edit committee. But truth is that the price on the internet is quite pricey. So there is really a lot to do, I think, and we will also need to move with some people in the corporate world. Thank you.
Thank you, Dr. Barbara. Dr. Miriam, can you throw some light on the same? How do you think we can use collaboration with stakeholders to kind of address the issues of inequalities?
Okay, thank you very much, Hope. I think that is a very relevant question. And I'll start off with Barbara's last comment about even things like Zoom meetings. Because if you think about it, even this meeting that we are attending right now is limited to people who are able to afford to pay for the internet and are in a place where there's internet access. There are fellow colleagues who are in more remote parts of the country who would have loved to be part of this discussion, but because of that, they're not able to participate. What I'm trying to get at here is that it's really important for us to find out who is the target audience for whatever it is, a medical device, a medical innovation, or a conference even like this, and find out who is our target audience, and then ask ourselves, are we able to reach them? Are they able to partake of this great innovation that we are coming up with? The other thing is also finding out so in the case of our patients, what do they want? So many times I feel like we come up with these innovations from our perspective and not from the perspective of the people we want to use it on. I have read of a number of scenarios where patients are involved in, first of all, determining even what topics of research are interesting, what kind of medical devices are necessary. So I believe that we are missing out that end. The key people we are developing these innovations for are not the people that are benefiting from it, because we are not asking them for what they need. And then finally, being in a university, we have access to many other colleges within the university. And a lot of the things that we are developing because of technology are really very techy. And so it would be very interesting if we intentionally involve like the departments of IT, people like engineering to come in, listen to what we are trying to make and help us translate those things into actual things. I know there are groups that have done this and it's working amazingly, but I think it should be a more intentional effort. Thank you.
Thank you, Dr. Miriam. Going back to Prosper, probably you've been at the forefront of developing the technologies that are being used, as you've explained to us earlier. So which stakeholders have you probably engaged or used to help you market or spread your innovation? And how helpful have they been?
Yes, thank you very much for that question. I find it a very pertinent question, especially for us, healthcare innovators who are the front line of this movement. So to bring this into perspective, I think it's very important, like Barbara shared earlier on, to have, the target communities at the center of your innovation. So I will give an example from the inception of Mobile Scan Uganda. So in 2017, when we were setting out, we actually did a needs assessment with Mubende district, which is the third largest district. So we're assessing why were mothers, in this district. It also had a high maternal mortality rate. It was among the top 5. So we're asking ourselves, where are the gaps? And we had to go and, profile mothers, talk to them, have a conversation with them. What are the challenges that you go through, during pregnancy? Since our focus was ultrasound, we had to ask, where is the nearest place that you're able to get an ultrasound? What is the distance that you have to carry, to cover? And how much do you have to pay to actually access an ultrasound? And what we got was very alarming. Mothers had to travel as far as 20 kilometers back and forth to actually get an ultrasound. And we had to bring all this into the innovation and say, what is needed here? So if Mubende, places like Mubende don't have electricity, the big machines cannot be maneuvered in some of these remote areas. We're like, something portable and affordable and accessible is what the people in Mulende need. So right from the journey, I think it's very important to bring the major stakeholders who are the beneficiaries. So in the innovation space, we call this a human-centered design. And I think this is something that should be fundamental when it comes to the development of any innovation or any innovation cycle. I would also want to hint on sustainability. How do we ensure that whatever we're developing is sustainable? So so the first step is including the major stakeholders in a human-centered design right from the inception. Two, I think we have to look at who are the partners, who are the people who have the big wings, to be able to scale your innovation, to support you, 1-2 years when you're not, at the site of execution of the innovation. So we reached out to Airtel Uganda. We have now they're able to provide us with data for some of the scans that are done, and midwives cannot, access. They cannot be able to tell which complication it is. They can refer to that case to a radiologist in Kampala, and they're able to get feedback then right there. We're also partnering with Ministry of Health with support from JICA Uganda. So I think we also need to look at who are these people with the wings to scale, and who have the resource, and who are interested in what you're doing. So whatever you're innovating for, there are people who are definitely interested in your work, but you have to begin, and along the journey as you're going, people will definitely come and dig into what you're doing. I also want to raise another question. I think we can have a debate on, which is financing. How can we develop platforms for sustainable financing for healthcare innovation that are addressing equity and inclusion? And I mean for not just mothers, but for people in refugee camps. I think recently there is a talk on LGBT, which is a bit very controversial in my country. But they also have healthcare needs. So it is the diversity is quite there, and we need to think of how can we continue supporting the ecosystem of healthcare innovation, right from inception to stakeholder engagement and to financing. Thank you.
Thank you very much, Prosper, for that quite elaborative explanation. And you bring in a very important issue of financing. I don't know if the question was to be addressed to the fellow speakers, or if it is something to think about still. But if anyone has something to respond, something to talk about financing, and yeah, we can talk about it. So when I get back to Dr. Catriona, any experience with engaging stakeholders in a way of helping us to widen or to improve, or in the process of implementing our technologies that we've developed? Do you have an example of that you can share with us? Meanwhile, you can keep your questions going through the chat. We shall respond to them as we go on. Thanks.
So thank you for the question. And Prosper, I really liked the way you brought in many key points during that brief summary of your work and the engagement that it requires and all the issues. The example I have, it's not my own research, but the best example I've come across in the literature is that in South Africa, there's an app called Mom Connect. So it's an app for gathering information about pregnant women, but it's also got a sort of two-way interactive process whereby mothers, expectant mothers, can submit questions, they can flag up any medication safety events and so forth. And they've actually achieved, I think, 63% coverage, so that over the last couple of years, around 63% of all pregnancies across South Africa, the women have registered with this app. And I think the thing that was key about it was they obviously did some pilot work to prove that it was a feasible and beneficial thing. So I think that's something that we need to remember with innovation. It's very easy to almost jump ahead of ourselves and say, this looks like it should bring benefit, therefore we're going to start using it and hope people take it up and hope it achieves benefit. But we actually do need to do research into that. And I'm sure this will be coming up in many parts of the conference. So if we have some pilot data that show that something is feasible, potentially the costs are different, but it actually might save money at the point of healthcare facility or transport, and it's achievable, it may benefit health, then the stakeholders are going to be interested. So with this Mom Connect platform in South Africa, the principal investigator and the Minister of Health, they almost did a joint launch, and they kind of moved around the country doing sensitization events. So it was like Ministry of Health in partnership with the researchers. And there was quite considerable subsidy from the mobile phone companies, because I believe the running costs were something like $1 million a year. So not insignificant. But by having the pilot data and then doing this almost partnership between investigators, Ministry of Health, mobile phone companies from the outset, it's achieved something that I find is quite outstanding. And there are papers in the literature that you can refer to as that. So I think it's a good exemplar that we can learn from. I don't know how achievable that is for some of our smaller things we're trying to start up in Uganda, but it's an example.
Thank you, Katrina, for that. Yes, it's a good example. It's just something to think about and see how you've said the smaller things are being implemented but not going, but it's something that we can think about as well and probably build up. And also takes me back to what Prosper asked us about financing and how can we develop a sustainable, way of financing. Does any of the speakers have something to comment on financing? Or Prosper's concern, or talk about how we can sustain, or ways that we can try to finance and create sustainability of the innovations that are being created. Dr. Barbara, any, or Katrina, any? Please, you can come in.
I was just very quickly going to say, I think evidence is key. Because if we do want people to invest, particularly if we want government and ministry to invest, we have to be able to present a case that it's worth investing in. So I think we do have to have that evidence. I don't know, Barbara, you perhaps have more to say on this.
Well, yes, I agree with you that you need some preliminary data, you need some evidence. The other thing is that I was just thinking, at simple things like running a virtual meeting, or again, running a virtual committee. These are actually innovations that use technology, which, I think eventually if you cost them, you may be saving money and time. If you think about people moving up and down, not using their fuel, not using their time. If you think, yes, it's true, the internet is expensive, but fuel in Uganda is crazily expensive either. Using a room. So some of these, substituting some of these, so using technology does not necessarily mean that you're going to spend more money. So I think that is another piece that someone has to look into. Of course, if you have a new device, that is going to cost you money. But there are things where we are now use technology in a smart way that may actually not require no financing. Over.
Thank you, Dr. Barbara and Katrina, for the suggestions or the insights on how we can sustain and probably trap more funding and sustain the innovation. Swinging you back to the current epidemic that is ongoing, I would like to know what you speakers think about this pandemic. What has it taught us about health inclusion and equity? To you, Dr. Miriam, what do you think? What lessons do you think we've learned? during this COVID-19 about health inclusion and equity.
Thank you very much, Hope. The first thing that I believe we've all learned from this pandemic is that even when things seem to be happening, moving very smoothly, we should not be comfortable because we never know when things are going to change and force us to change along with them. The second thing, what I've learned about equity and inclusion in this pandemic is that if we're not conscious and don't make it a conscious effort to reduce or to bridge the gaps between the wealthier people who have a bit more and the people living who have less, then when you have a pandemic like this, the gap widens. A simple example is just look at the medical system now. During COVID, there was a time when, especially during our second peak in June and July, the people who were not, there was a lot of COVID testing available, but they were accessible to a certain class of society. I mean, you could call and have people come and do your COVID testing at home. It wasn't free, minimum about 70,000 shillings. What proportion of Ugandans were able to afford that? So even if technology had advanced so much that you could call people, have your test at home, get your results by email, it was limited to the few people who had access to these calling facilities, WhatsApp, which was a common medium being used, and then able to pay for this service. Look at the admissions in hospital. They kept talking about the millions of shillings that admissions was costing. You cannot say the only people that had COVID enough to need admission into hospital were the wealthier people. But the divide has just grown because it has never been a conscious effort to bridge the gap between those who can afford these advancements in technology and those who cannot meet those expenses. And so going forward, I believe that whatever advances we're coming up with, and even with the existing technologies, we need to look and say, is this equitably reaching everyone in society? And if it is not, what do we need to do? How do we bridge these gaps? Does it mean, should we look for alternative technologies? What should we do to make sure that everyone has equal access to the advancing technology that we have around us? Thank you.
May I say something?
Yes, please, Dr. Barbara. Yes, please, Dr. Go ahead.
So I was just reflecting on what Miriam just said, and I think that the disparity in the access of health or technology may vary from country to country. I think the specific example of Miriam gave, of course, works very well for Uganda, where everything you have to do costs you money. I was thinking, I've been in touch, of course, with people in Europe, particularly my country, Italy, who was really hit very badly by COVID. And because we do have a totally free public system, what happened is that this COVID pandemic actually was very democratic. It didn't matter if you had money or not. If there were no beds in ICU, you would just die at home. And instead, the disparity of access, the way I see, it was really driven mostly by age, with the old people finding themselves young people, they were already on WhatsApp with their friends, on Facebook. And now when they start saying, okay, virtual learning, maybe they've not done before, but they were, it was easy for them to get on Zoom. But now think about people 60, 70, 80 and above. These people, they didn't even study computers when they were in school. Now for everything, all of a sudden you need a smartphone, you need a laptop, bank closed, everything went online, and elderly were really lost there. So I think also, the approach of access to health and technology may vary from the setting where you are. Here may be a matter of education, for example, or like Miriam said, a matter of wealth, but in other places it may be a matter of simply age. And that's why I think, as Katrina mentioned, one of the first talks, it is very important that you understand what you have on the ground, because what you learn from another country may not necessarily be applicable in our context. Thank you.
And Barbara, I would like to follow up on that point also, that I think we have to
Thank you, Dr. Barbara and Katrina, for
I think Katrina was trying to speak.
Sorry, I don't know if it's my connection or theirs. I was following up on your point, Dr. Barbara, that with any technology, we have to be careful that it's not the only way. So if there's a technology that's aiming at perhaps a particular group in society, we have to make sure that there is a way for people who don't have that technology to still be able to access healthcare. Because I think that's what we've been seeing in some of the high income countries, but probably also in Uganda, this digital divide, that if you can't access technology, you've been lost. And whilst COVID was an extreme situation because we were all locked down, and it could be argued that without technology, everybody would be lost. So actually, it's better than it would have been if the technologies weren't there. We have to be careful that we have more than one approach. So we don't neglect simple things, radio messaging, other ways of reaching out to vulnerable people. Thank you.
Thank you, Dr. Katrina. Dr. Prosper, any lessons that you've learned of regarding inclusion and equity and this era of COVID pandemic that has been on?
Oh, thank you. I think there's been a lot of learnings for me as regards healthcare innovation and even the work that we are doing, but also as someone who is interested in how we improve our healthcare systems. I think when COVID came, we had inefficiencies in the healthcare systems. We, for example, had about less than 100 ICU beds in Uganda, and here we are trying to deal with a pandemic where the most severe patients would require support, by a machine, to breathe by a machine. And it was very unfortunate that through the pandemic, the beefing up of a healthcare system, especially tertiary healthcare, happened like almost 8 months into the pandemic. And so I think that we have not, I think some of the lessons were learned the hard way, which was very unfortunate because we lost a lot of lives because of our unpreparedness. I would also want to talk about, I think, currently where we are in the phase of the pandemic, which is vaccination, and how can we get to herd immunity as nation and be able to end the pandemic. I think what has been, I will agree with Dr. Barbara that the inequalities that we have in our healthcare system, both are demographic, but they are global, but they're also regional. So you find, for example, the only vaccine manufacturing plant we have on the African continent is in South Africa, and it's not been able to provide the required amount of vaccines, the access. You will also talk about how prepared were our governments, to buy these vaccines and make sure that everyone is vaccinated and we're able to reach, herd immunity. So these are some of the global inequalities that we have to, access of healthcare, especially as regards the pandemic. But when you come to Uganda, you still find that there are people in urban centers who have access to electricity, smartphones. They have been using them, and those who cannot, who are not, for example, in the pandemic, able to use their phones to, for example, talk to a doctor, have a video chat with a healthcare provider because they're unable to move. We found that a challenge. So the pandemic also highlighted the need for telemedicine and digital platforms in delivery of healthcare. And I think for me, that was also one of the highlights that I got. So underlying those is all these inequities that we have. So I think it is just, it's on us to learn and take these lessons and make sure that we learn and effect some of these changes and make sure we are prepared for the next pandemic. So before we get from this one, so I think that for me, those are some of my highlights that I got from this pandemic. But I think we are stronger. We've taken our lessons, and as healthcare innovators, we've not been sleeping. We have really responded to the changing needs of some of the segments of our healthcare system.
Thank you, Dr. Prosper. Maybe as we near the end, I had one more concern about the vulnerable populations. For example, the refugees, the children, the mental ill patients, or our clients that we reach. How have we thought about them in regard to inclusion and equity in this era of COVID, but also as we develop our technology and then the innovations? Have we tried to put in place or to consider them the way we could, how to reach them with the innovations that we have? Dr. Barbara?
I'm not very prepared to answer this. So I think it really depends on the population, right? So, for example, if you mention the children, definitely you have to target their parents. So, honestly, I do not work with special populations, except mainly the elderly, which I already mentioned is a bit problematic. Not problematic, but they are less likely to adapt actually to technology or to like technology and innovation, by the way. By that time, you're very conservative, and you're used to the fact that you need to see the doctor physically. You know, it's also that kind of counseling that happens during the medical visit. So that is a population which I think we can target. You know, it is a limited target, unless, for example, you may have most of these elderly, they have relatives. And so if you want to engage them, usually I think you have to do it through their grandchildren or children. So a lot of elderly people, when during lockdown in Europe, when everything became virtual, including banking, so they can't pay for anything, they actually call their grandchildren to help them. And so, you know, to download their app, to show them how to work, or maybe just do the operations for them. So probably for some of these special population, you need to find who is the person next to them, who is likely to embrace technology and support them. I don't know if the others are other suggestions. Mentally ill, that one is a bit, I think, difficult. Again, probably you need to find the next of kin or someone. I think this population are very difficult to target directly. I personally think you need to go around them. Thank you.
And I was going to follow up on that many of these people we consider vulnerable are not living alone. And actually in Uganda, we often talk about being resource limited or resource poor, but actually we have this wonderful resource of strong family groups and communities. And so I think sometimes for some of the interventions, it's not so much thinking of the individual and targeting the individual, but it's almost targeting small community groups. So for example, with regard to pharmacovigilance and the fact that people can report their own medication safety events using an app, the way I see it going is I don't imagine that every single person in a community would have that, but you could have 2 or 3 people who became almost like lay experts within that community who could be known as those are the pharmacovigilance people. So I might know if I take my medication and I get a rash, I go and see Auntie Florence who lives just down there because she's the one that knows how to use the app. So I think when you look at how technology is used in Italy, UK, America, we are very individualistic societies. And therefore you are targeting the individual and people are very, very private about many, many things. Whereas I think in Uganda, and this is where community involvement would be key to find out what people want and what they're willing to share with, say, their neighbor. But I think targeting community groups so that we know that there's one person in that community that can do this would be a way forward.
Thank you, Katrina, for that. I personally could use, can give a personal experience from personal experience from the projects, for example, we are implementing in the Karamoja region. We are using technology to see that if we improve the treatment outcomes for the patients on TB treatment. And as Katrina and Dr. Barbara have highlighted, is that here in Africa or in Uganda, we have caregivers or caretakers, and we've been able to help our patients, for example, who don't have the gadgets, who are unable, the elderly, who are unable to use the technology through their caregivers. And that has really showed a good outcome for the patient, the main patient, but we go through their caretaker or their relative to monitor them. And I think using the people close to us, especially here in Africa and in Uganda in particular, we can be able to reach the people through either the close relatives or the caretakers. And I think that's, really good. Dr. Miriam, you have some submission?
Yes, I do have something to say. I know that most of the times the vulnerable people in our community have family or close relatives with them. However, there is we cannot ignore the fact that there are some who have no immediate family, and that is where the community health workers come in. We have, so the community health workers are part of the Ministry of Health cadres, but these are groups of people to whom we should intentionally also reach out and get involved in the technological advances, because this is a group of people who can help us to reach the unreachable, reach the people who are hard to reach, and also to help with the people who are vulnerable in the community. So let's not forget the community health workers.
Thank you, Dr. Miriam, for that reminder. Yet we have village health team and the other people that link people from the community to the facilities and who people trust. So we could also use that avenue. Prosper, any contribution to that as we wind up on the vulnerable populations, for example, from your experience dealing with communities?
Well, I think that vulnerable communities have very, as regards the healthcare, and for one to really understand them, is actually to go and reach out to them. Some of them have unexpressed needs. They don't know that they are sick. They think that is, for example, if someone has, for example, Northern Uganda, you find people with nodding disease, and they think that they are bewitched. So they are not expressing their need, but it's a healthcare need that actually can be addressed by a healthcare provider. I think, so that is as regards as that. I think I also want to, I will definitely want to agree that the pandemic has, you mentioned on something that there are healthcare needs that are coming out of the pandemic, and for me those are, for example, mental health. I think it's going to become another pandemic because people have been locked up, unable to communicate, and there's this whole thing around COVID, the fear, but of course that has gone down, but it has had a toll on some of the mental health of people, especially if you talk about now like children who have been out of school. Uganda now is on record. We don't have our children in school. It's, I think, the country with the longest time that it has taken for children to go to school, and that has had an effect on their mental health. So are we looking at, have we taken time to look at both what has happened and what are some of the things that are going to come out due to some of the measures we have put to curb the pandemic? And I think we need to zoom out and look at 5-10 years from now. How is the situation going to be because of the COVID-19 pandemic? But last, I would also want to really agree with Katrina and Barbara as regards how do we design healthcare innovations, and looking at the peculiar landscape in regards all how our societies are built. So I think that's a takeaway for me, that in the US people are very individualistic. But in Uganda, if, for example, someone has a grandma and they're able to, they can be able to help the grandmother access healthcare because they share, they're able to share that bonding that they have. And I think those are some of the things that we need to highlight moving forward as we deliver our healthcare innovation.
Thank you, Prosper. We have shared a link to the main plenary session on mental health clinic. So please look at the, it has been shared on the chat. Kindly join us after this if you can. So as we wind up, I will start with Catriona, one more last word to the participants of the session as we go around, and then we call it.
I think my last word is that innovations are exciting. I think many of us have said, how would this pandemic have been had it been 15, 20 years ago? And actually, innovation has allowed many of us to continue with our life and our work and reaching our patients, and innovations have transformed how we live. I think a note of caution is just that evaluation is key, and to take time to think carefully about what we are doing, why, who we are trying to reach. And a minor point, or that's not minor actually, that we didn't discuss is what happens to any data. So if we get to a point where people are inputting perhaps personal data into apps and things, have we got very rigorous data protection systems and so forth in place that really protects our participants, our patients? Because the worst thing we could do would be to be well-meaning, but accidentally make things worse and, you know, not take all the risks into consideration. So for that reason, I'm excited you're having this conference. I've been honored to join the panel, and thank you very much.
Thank you, Dr. Catriona, for joining us as well. Dr. Miriam, your last word to that.
Thank you very much. So my last words to the people who have been part of this forum is to remember that even when we are talking about the gaps that have developed as a result of technological advances, we are not saying these technological advances are wrong. They actually are excellent. And as much as possible, they need to be strategic, because just like we have seen, if we hadn't been strategic in a number of things, COVID would have come in and floored us. See how quickly the vaccine was developed, because someone somewhere was working on a more advanced and faster method of developing vaccines. The last thing is that we should remember that even when we come up with new technologies, we should not be too fast to get rid or to make obsolete what was existing in its place, because not everyone who is supposed to benefit from these technologies will be able to access it at the same time equitably. So we should make sure it's a calculated and slow transition to allow everybody to catch up. And finally, once again, involvement of the key stakeholders. Who are the users? I may be excited about this new technology, but I need to think about who is it going to actually benefit, and do they have an input into what it is that we are coming up with? Who is going to finance it? Have I involve them in the discussions early? So key stakeholder involvement is really important. So even if it is your brain that came up with the idea, remember that no human being is an island. We need each other to be able to be successful. Thank you.
Thank you, Miriam, for that. Dr. Prosper, your final word to the participant.
Well, I would love to thank everyone who has come through to attend this conference. And one, I would also want to, first of all, thank IDEA and the Academy for Healthcare Innovation in Uganda, I think, for providing the platform and the leadership as regards healthcare innovation in Uganda. I think that is very commendable. The key things that I think I'm taking away from this, and I would also love to share with the rest of those who are listening, I think that innovation, healthcare innovation, is a new way in which we're addressing some of the biggest challenges we have in our healthcare. And I think health innovations they're like a Trojan horse for us to actually level the ground in terms of improving access and the quality of healthcare for marginalized communities. be it refugees, be it far distant areas like islands, Karamoja. I think we have the opportunity to innovate for them, but more importantly, we should involve them as the major stakeholders. I would also love to thank Dr. Miriam for hinting on what we need to do in terms of how can we make healthcare innovation very sustainable. I think as active players in the space, for us, we're finding it a challenge, but also it has been an opportunity to grow and get on stakeholders and involve them in what we are doing and scale our impact across Uganda. And one thing I would also love to challenge other healthcare innovators that, healthcare, for example, if you talk about maternal mortality, it's mostly in sub-Saharan Africa and Southern Asia, where we lose about 830 mothers every day due to complications of maternal or pregnancy. And so whatever you're doing in this space can be replicated across. So not just look at stakeholders at the country level, you can look at stakeholders, Google and all these people who have the platforms to extend your healthcare, to extend your innovation across the board. The other thing I think that I'm taking away is how do we keep evidence? How do we develop the evidence that our healthcare innovations are working and they're creating impact? I think that's also one of the ways that we can present this to attract sustainable partners to be able to scale, and also to really put the heart of community in whatever we are doing. So those are my nuggets, and I'm glad to have been a part of this conference and to share my insights. And I would love to thank all the panelists who have joined me. I've really appreciated. I've tapped into your experience, and I think it's been a very wonderful conversation around healthcare innovation. Thank you.
Thank you, Prosper, for those words. So lastly, I call upon Dr. Barbara to give us her closing or last.
So I think that what I would like to say that has not been already shared is that, yes, I think technology and innovation has a place in health. Also, if you want to say like in normal times. Of course, during this COVID time, it has been a blessing because Katrina mentioned it. This had happened 15, but even 10 years ago, probably. We would really be in serious trouble with all these lockdowns. But I would like to say that technology needs to be used wisely and should not substitute humans. Should support human work, but not being a substitute. And I will give you an example. It's so irritating when basically you're just, I don't know if it happened to you, you're just talking to a robot and you cannot get a person. Some years ago, I lost my luggage at the airport in Milan, and you dial this number and then they keep referring like, if you lost your luggage, press 1. If you do this, press 5. And you keep pressing, but there is never an end where you can actually talk to someone. And that is really frustrating because sometimes all you need is to hear a voice and tell, Madam, this is the airplane, don't worry, And so I think we really have to balance. I'm sure in the future, we're going to have more and more technology, more and more innovation. But I think we really don't have to forget that there is nothing nicer than a human touch, nothing nicer as a human voice. So I really think that technology and innovation will not completely substitute what a human being can do for you in presence or even on the phone. And with this, I would like to thank the organizers for inviting me, for inviting us, and the other panelists for the discussion. Thank you.
Thank you so much, Dr. Barbara, and the rest of the speakers. We are really honored to have had you on this conference, for saving your time, giving us your time to be part of us. We are really, really honored. And thank you, and thank you. very much. And please, we'll hold this every year, and we hope to see you again on the next conference as both as the participant and as a speaker if you're called on. We thank you so much. And I also thank the people who have joined in to participate. Thank you very much for your time. With that, I will call this discussion closed. Thank you so much. Kindly join the next session. The link has been shared. Thank you. God bless you.
Thank you. Bye.